What's up, my average med students? Welcome back to another episode. Today we're going to be covering infectious disease from the TZANKI Step 2 deck. If you haven't already done so, please hit the subscribe button and press the bell icon to be notified of future posts. Happy studying.
1. Actinomyces species and Nocardia species are both gram-positive bacteria that form long, branching filaments resembling fungi. 3. Which gram-positive, filamentous bacteria is associated with yellow sulfur granules? Actinomyces species. 4. Flucitocin is an antifungal agent that is used combination with amphotericin B to treat cryptococcus, especially meningitis caused by cryptococcus. 5. What is the treatment for neurosyphilis in a patient with penicillin allergy? IV penicillin after desensitization. Allergy equals treat with doxycycline. Allergy plus neurosyphilis or pregnancy equals desensitization to penicillin. 6. What WBC level is seen on lumbar puncture and bacterial meningitis? Greater than 1,000. 7. At what age is the herpes zoster shingles vaccine recommended in all adults? Greater than 60 years old to prevent shingles and mitigate symptoms if shingles does occur. 8. What life-threatening reaction is associated with nevirapine HIV therapy? Liver failure. 9. TMP SMX is used in HIV-positive patients to prevent opportunistic infections caused by Pneumocystis jirovecii and Toxoplasma gondii when CD4 count is lesser than 200 for PCP, 100 for Toxo. Azithromycin is recommended for prophylaxis against MAC when CD4 count is lesser than 50. 10. Bacillary angiomatosis is a bacterial infection that presents in HIV patients with exophytic purple skin masses and visceral angioma-like blood vessel growths. Treat with antibiotics. 11. Hepatitis C can be asymptomatic or develop fatigue, arthralgias, weakness, weight loss, and serum transaminases can be elevated or normal. Extrahepatic manifestations include heme, essential mixed cryoglobulinemia, renal, MPG, and skin, porphyria cutanea tarda, lichen planus endocrine, increased risk for diabetes. 12. A patient presents with fever and cough. Physical exam reveals foul breath. Chest X-ray reveals a cavitary lesion in the right lung. You suspect a lung abscess. An incision and drainage with culture is done. Until the culture is complete, what is the most appropriate empiric treatment? Clindamycin lung abscess. Key points. Abscesses don't just form out of nowhere. These patients typically have an aspiration risk. Empiric treatment with clindamycin is recommended again. Due to the aspiration risk, most lung abscesses involve anaerobes. Aspiration risk is typically secondary to seizure, alcoholism, MS, or stroke. Give proper treatment once culture and sensitivity return. 13. A patient is diagnosed with syphilis and is given the appropriate penicillin treatment. Following treatment, the patient develops fever and his symptoms worsen. What is this phenomenon called? Jarisch-Herxheimer reaction. Treat with aspirin. This is secondary to widespread endotoxin release following the death of bacteria. While classically associated with syphilis and other spirochete diseases, it can occur in other cases due to rapid lyses of spirochetes, self-limited and resolves spontaneously within 48 hours. 14. A patient is diagnosed with Lyme disease. She has erythema migrans, arthralgias, and AV block. What is the treatment? IV ceftriaxone. 15. What is the notable side effect of the anti-HIV drug indinavir? Nephrolithiasis. Indigo princess. 16. A patient who develops polyarthralgia, tenosynovitis, and painless vesiculopustular skin lesions have the classic triad for disseminated gonococcal infection. 17. Neurological symptoms with CD4 count lesser than 200. Imaging shows multiple non-enhancing lesions, PMLJC virus. 18. What is the most likely diagnosis for linear ulcerations found in the esophagus on endoscopy? CMV. 19. What is the treatment for Whipple disease? IV ceftriaxone and maintenance TMP-SMX for 1 year, lethal if left untreated. 20. What rapid test can be done in the diagnosis of histoplasmosis? Serum, urine rapid antigen test. 21. What systemic fungi can produce verrucous skin lesions when disseminated? Blastomyces. 22. What beta-lactam antibiotic can be used for left-sided endocarditis caused by strep viridans and strep bovis? IV penicillin G. Most viridans group streptococci are highly susceptible to penicillin and should be treated with IV aqueous penicillin G, not oral or IV ceftriaxone. Oral antibiotics are generally not recommended as initial therapy in PT. With infectious endocarditis. 23. What is the cutaneous complication of vancomycin and how do you treat it? Diffuse flushing red man syndrome due to histamine release, managed by slowing the rate of infusion or pre-treating with antihistamines. 24. What drugs should be used to treat toxoplasmosis? Pyrimethymine, sulfatazine. 25. Pyrimethymine, sulfatazine is used to treat what protozoal infection? Toxoplasmosis HIV patient with headaches, functional neurologic disorder, and multiple ring-enhancing lesions. Mnemonic, pirating and stealing is toxic. P for pyrimethymine and S for sulfatazine. 26. Rapid diagnosis, treatment of Nocardia. Sulfonamides TMP-SMX. 27. What is the substitute for patients with H. pylori who are penicillin allergic? Metronidazole. 28. What should be avoided with the use of metronidazole? Alcohol due to disulfiram-like effect. Disulfiram is a drug given to alcoholics that inhibits aldehyde dehydrogenase, can't metabolize acetaldehyde, and produces warmth, flushing, sweating. Unclear mechanism. 29. What antiretroviral therapy is associated with a type IV hypersensitivity reaction? Stevens-Johnson. Abacavir. 30. Abacavir hypersensitivity is associated with the HLA-B57, 1 allele. 31. Idanosine is an NRTI most commonly associated with which adverse effect? Pancreatitis. 32. What combination therapy is used for the treatment of cryptococcal meningitis? Amphotericin B, flucitosine. 33. Itraconazole is an azole that is used to treat Sporothrix schenkii sporotrichosis. 34. S. epidermidis is a coagulase-negative, gram-plus organism that infects prosthetic devices, hip implants, heart valves, and IV catheters by producing biofilms. 35. What are the CNS complications of nocardia? Brain abscess formation. 36. Nocardia is a filamentous branching gram-positive organism that can cause a brain abscess, fever plus functional neurologic disorder. 37. What is the treatment of Sporothrix schenkii? Itraconazole first line, potassium iodide not used anymore. 38. Patients using asthma inhalers or oral steroids are at risk of oral candidiasis. 39. What is the likely diagnosis in an afebrile farmer with RUQ pain and a smooth, round hepatic cyst with septations and eggshell calcifications on ultrasound? Echinococcus granulosus infection. Lack of fever and cystic lesion favor Echinococcus rather than Entamoeba histolytica febrile with a smooth, cystic subcapsular mass. Ultrasound shows hepatic cyst with daughter cysts internal septations. 40. How do humans typically contract an Echinococcus granulosus infection? Consumption of food or water contaminated with dog feces. Sheep are the intermediate host. 41. What is the likely microorganism causing a UTI in a young female with an elevated urine pH and renal calculus on imaging? Proteus mirabilis, more likely than E. coli given the urine alkalinization and presence of a renal calculus struvite stone. 42. What is the likely causative microorganism in a patient with infective endocarditis after having a tooth extraction 1 month ago? Viridans group Streptococci. 43. What is the typical empiric treatment for patients with human bite wounds? Amoxicillin clavulanate. Human bite wounds are often polymicrobial with both aerobic and anaerobic oral organisms. 44. What is the likely diagnosis in a patient that presents with flu-like symptoms without a rash after being bitten by a tick 2 weeks ago in Georgia? Laboratory exam reveals leukopenia, thrombocytopenia, and elevated LFTs. Ehrlichiosis carried by ticks, including the Lone Star tick Amblyomma americanum, in southeastern and south-central United States. Ehrlichopenia, leukopenia, babesiocytosis, leukocytosis. Babesiosis has leukocytosis and is in northeast. 45. What is the empiric treatment for ehrlichiosis? Doxycycline. 46. What is the initial treatment of choice for most patients with early localized Lyme disease? Oral doxycycline. Amoxicillin may be used in children lesser than 8 years old and pregnant women, where doxycycline is contraindicated. 47. What is the likely diagnosis in an HIV patient that presents with fever and altered mental status with encapsulated yeast visualized on CSF fungal stain? Cryptococcal meningoencephalitis caused by Cryptococcus neoformans, typically in HIV patients with CD4+ count lesser than 100. 48. What is the likely diagnosis in a patient that develops sudden onset abdominal pain, nausea, and vomiting after returning from a hike and eating leftover Chinese food? Bacillus cereus, food poisoning characterized by rapid symptom onset 1 to 6 hours due to performed enterotoxin. Vomiting is the primary manifestation. 49. What is the likely diagnosis in a patient that presents with fever, sore throat, drooling, and muffled voice? The bilateral submandibular area is tender and indurated with palpable crepitus. Ludwig angina, rapidly progressive cellulitis of the submandibular space, usually due to dental infections. Treatment involves IV antibiotics and removal of the inciting tooth. 50. What is the likely chief complaint in a patient diagnosed with Cryptosporidium parvum infection? Prolonged, profuse, watery diarrhea, typically 10 to 14 days. Traveler's diarrhea that is prolonged, profuse, and watery is often due to a parasitic pathogen. Patients may also complain of nausea, abdominal pain, low-grade fever, or malaise. 51. What is the treatment of choice for an HIV patient with pneumocystis pneumonia and a partial O2 of 54 mmHg, normal 75 to 105 mmHg? Trimethoprim sulfamethoxazole and corticosteroids. Corticosteroids are indicated for patients with PCP if O2 sat lesser than 92%, partial O2 35 mmHg on room air. 52. What are the recommended empiric antibiotics for immunocompromised patients with suspected bacterial meningitis? Vancomycin plus ampicillin plus cefepime provides coverage for major organisms of bacterial meningitis and Pseudomonas cefepime, Listeria ampicillin, and cephalosporin-resistant pneumococci. Vancomycin. Rules of thumb: really young, lesser than 1 month, ampicillin, listeria, and cefotaxime prevent kernicterus. Kinda young to kinda old, vancomycin plus 3rd gen cephalosporin ceftriaxone old greater than 50, plus ampicillin, listeria, immunocompromised. Look for option with cefepime to cover pseudomonas in neonates. Cefotaxime is preferred over ceftriaxone because ceftriaxone can displace bilirubin from albumin, increasing the risk of kernicterus. 53. In addition to empiric antibiotics, what other medication should be administered to patients with suspected bacterial meningitis? Corticosteroids helps prevent the neurological deficits associated with pneumococcal meningitis. For example, deafness, focal deficits should be discontinued if pneumococcal meningitis is ruled out. 54. What bacteria is the most common cause of community-acquired bacterial meningitis? Streptococcus pneumoniae. Treatment typically involves vancomycin and a 3rd-generation cephalosporin plus or minus ampicillin. Strep pneumonia may occur with or without concurrent pneumococcal pneumonia. 55. Patients with suspected aspiration pneumonia should be treated with antibiotics that include anaerobic coverage. For example, clindamycin, metronidazole plus amoxicillin, amoxicillin clavulanate. 56. What is the likely causative organism in an immunocompromised patient with multiple lung cavitary lesions and brain abscesses identified on imaging? Sputum cultures grow partially acid-fast, gram-positive, branching rods. Nocardia. 57. What is the likely diagnosis in a patient who recently emigrated from Mexico and presents with fever, RUQ pain, and bloody diarrhea with a subcapsular liver cyst visible on CT? Amoebiasis liver abscess secondary to Entamoeba histolytica. Presence of fever and a subcapsular liver cyst helps differentiate amoebiasis from Echinococcus granulosus, a febrile with a hydatid liver cyst. 58. What type of catheterization is recommended for patients with neurogenic bladder to reduce the risk of catheter-associated UTI? Clean intermittent catheterization, for example insertion, removal of a clean urinary catheter every 4 to 6 hours, can be performed by patient or caregiver. 59. What is the likely diagnosis in a young adult that presents with headache, fatigue, persistent dry cough, and mild sore throat? There is a faint macular rash on the arms, legs, and increased interstitial markings on chest X-ray. Mycoplasma pneumoniae infection. Atypical pneumonia patients may also have mild hemolytic anemia due to cold agglutinin. Treatment is empiric macrolide or respiratory fluoroquinolone therapy. Dry cough differential, mycoplasma, viruses, Coxiella, pneumocystis, chlamydia. 60. What neurological side effect is associated with isoniazid use? Peripheral neuropathy secondary to pyridoxine deficiency. 61. What is the likely diagnosis in a patient that presents with high-grade fever, cough, diarrhea, confusion, and hyponatremia? Chest X-ray reveals a right lower lobar infiltrate. Legionella pneumoniae, Legionnaire's disease. 62. What is the next step in management for a patient with suspected ventilator-associated pneumonia with a chest X-ray demonstrating lobar infiltrate? Gram stain. Culture of respiratory secretions should be obtained prior to administering empiric antibiotics. 63. What is the likely diagnosis in a college student with a recent viral URI that presents with high-grade fever, productive cough with hemoptysis, and leukopenia? Chest X-ray reveals bilateral alveolar infiltrates and multiple cavitations. Community-acquired methicillin-resistant Staphylococcus aureus. Community-acquired MRSA infection. Community-acquired MRSA has a predilection for young patients with recent influenza. Community-acquired MRSA causes necrotizing pneumonia with multiple cavitary lesions. 64. What is the recommended tetanus prophylaxis in an adult that suffers a severe wound after stepping on rusty nails? He is uncertain of his vaccination history. Tetanus toxoid containing vaccine and tetanus immune globulin. 65. What is the likely diagnosis in a patient that emigrated from Southeast Asia and presents with a well-circumscribed, hypopigmented patch on the arm with no sensation to pinprick? The ulnar nerve on the ipsilateral arm is thickened and tender. Leprosy. Leprosy typically affects the skin and peripheral nerves. Diagnosed with biopsy of skin lesion. 66. What is the recommended treatment for primary syphilis in a non-pregnant patient with a severe penicillin allergy, for example anaphylaxis? Oral doxycycline allergy. Treat with doxycycline allergy plus neurosyphilis or pregnancy, desensitization to penicillin. 67. What is the likely diagnosis in a hemodynamically unstable patient that presents with fever, vomiting, and a diffuse, confluent maculopapular rash on the trunk and extremities? The patient recently had anterior packing in the emergency department for a nosebleed. Labs show platelet count of 55,000 and normal WBC. Toxic shock syndrome secondary to Staphylococcus aureus, likely due to unremoved nasal packing since there is no test for toxic shock syndrome. S. aureus and blood cultures are often negative. High index of clinical suspicion is important for diagnosis. 1. High fever, hypotension, shock. 2. Diffuse maculopapular rash covering palms and soles similar to sunburn. 3. Multisystem involvement, thrombocytopenia, myalgias, vomiting, diarrhea, altered mental status, etc. 68. What is the likely diagnosis in an HIV patient that presents with a 2-month history of low-grade fever and a productive cough that is worse in the morning? Chest X-ray below. Mycobacterium tuberculosis infection reactivation. TB preferentially infects the lung apices and presents with subacute or chronic symptoms. Reactivation is more common in HIV patients. 69. What supplements should be given with treatment? Active tuberculosis should be treated with 2 months of ripe rifampin, isoniazid, pyrazinamide, ethambutol, followed by 4 months of just isoniazid and rifampin. What supplements should be given with treatment? B6 with isoniazid induces B6 deficiency, can produce niacin deficiency. Diagnosed with sputum specimens for acid-fast bacilli smear microscopy, culture, and nucleic acid amplification before starting empirical antibiotic therapy. 70. What is the most common etiology of mixed cryoglobulinemia? Hepatitis C. What is mixed cryoglobulinemia? Low yield but informative. Vasculitis caused by deposition of circulating cryoglobulins that contain IgG and IgM rheumatoid factor directed against IgG mixed cryoglobulins. 71. Geographical distribution of histoplasmosis, Mississippi and Ohio River Valley blastomycosis, eastern, central U.S. coccidioidomycosis, southwestern U.S. coliparacoccidioidomycosis, Latin America. 72. Tetanus prophylaxis for severe puncture wounds with unknown vaccination history. Tdap, tetanus immunoglobulin. 73. Rapid diagnosis, erythema migrans bull's-eye lesion associated with Lyme's disease stage 1. 74. What is the treatment for an adult with Lyme with Bell's palsy? Doxycycline. Adults. What is the treatment for disseminated Lyme disease? Other neurologic signs other than isolated CN, palsy and cardiac signs. Ceftriaxone localized, doxycycline. Adults, amoxicillin. Pregnant and pediatrics. Disseminated CNS, carditis, ceftriaxone. 75. Amoxicillin is the treatment of choice for early, localized Lyme disease in pregnant and pediatric patients. 76. What will the hepatitis serology show for a resolved infection? Plus anti-HBs and plus anti-HBsAg1. HBsAg, infection recent or chronic. 2. Anti-HBs, immunity vaccine or infection. 3. Anti-HBc, IgM recent or IgG chronic. 4. HBeAg, infectivity. 5. Anti-HBe, low infectivity. 77. Describe the key features of primary, secondary, and tertiary syphilis. Primary, painless chancre ulcer. Secondary, 2 to 6 months. Systemic symptoms, diffuse rash including palms and soles, epitrochlear lymphadenopathy, condyloma lata, anogenital wart-like lesions. Tertiary, tabes dorsalis, aortic aneurysm, vulvar gumma. 78. What is the diagnostic evaluation in ventilator-associated pneumonia? Chest X-ray. If positive for pulmonary infiltrates, respiratory tract sample for culture and stain. Tracheobronchial aspiration, due prior to starting antibiotics. VAP. Pulmonary infiltrates with one or more of the following: fever, purulent secretions, leukocytosis, difficulty with ventilation. 79. What is the differential diagnosis for ring-enhancing lesions in patients with HIV? Toxoplasmosis multiple and CNS lymphoma single. 80. Chronic pulmonary aspergillosis. Aspergilloma manifests with greater than 3 months. Weight loss, cough, hemoptysis in patients with history of underlying lung disease. TB, sarcoidosis. Air fluid crescent shape seen on imaging. 81. When should you receive a rabies post-exposure prophylaxis? High-risk wild animal bat, raccoon, etc. unprovoked attack by stray dog that cannot be observed if prophylaxis is required. What should it include? Passive immunization. Administer human rabies immunoglobulin active vaccine in 4 intramuscular doses if previously immunized against rabies. Only vaccine is required. 82. Erysipelas is a skin infection of the upper dermis most commonly caused by group of strep S pyogenes. 84. Rapid diagnosis. Patient has history of bloody diarrhea with liver abscess found on imaging. What is the diagnosis and treatment? Entamoeba histolytica metronidazole. 85. Taenia solium is a tapeworm that produces gastrointestinal symptoms transmitted via undercooked pork. In intestinal teniasis, transmission is via ingestion in raw, undercooked pork. In neurocysticercosis, transmission is via eggs and feces. 86. What is the recommended HIV prophylaxis, if any, for a phlebotomist who got blood in her eyes while drawing from a male patient who has a history of sex with men and IV drug use? 3-drug antiretroviral therapy. Tenofovir and tricetabine plus integrase inhibitor for 4 weeks started immediately. This person has unknown HIV status, but still has high risk factors. 88. Do not perform a lumbar puncture if patient has any of the mnemonic, FILSFNDAMS immunosuppressed, ICP lesion at site of needle seizures. Want to make sure there is no increased ICP. If there is, you can cause brain herniation and death. 89. Rapid diagnosis, AIDS PT. With fever, headache, greater than 20 centimeters H2O opening pressure cryptococcal meningitis, look for crypto-antigen over India ink. India ink is not sensitive. 90. Cytomegalovirus bloody and Mycobacterium avium watery can cause diarrhea in AIDS patients with CD counts lesser than 50. 91. Rapid diagnosis. What organism should be most suspected in plantar puncture wound osteomyelitis? Pseudomonas aeruginosa. 92. Rapid diagnosis. Patient with recent tick bite in Georgia, leukopenia, thrombocytopenia, elevated transaminases, and elevated LDH. Ehrlichiosis TX with doxycycline spotless RMSF Lyme disease and Rocky Mountain spotted fever are less likely given the absence of rash. Babesiosis will have leukocytosis and is in northeast. Ehrlichiosis also presents without a rash spotless RMSF. Think babesiosis if there is leukocytosis and signs of intravascular hemolysis. Ehrlichiosis has leukopenia, thrombocytopenia, and is in southeast. 93. Rapid diagnosis. Fever, diarrhea, cough, and hyponatremia. Legionella macrolides, fluoroquinolones. 94. Rapid diagnosis. A patient comes in with progressive ascending paralysis, history of recent hiking trip, normal vitals, and normal CSF analysis. Most likely cause: tick-borne paralysis, neurotoxins from ticks. Don't confuse with Guillain-Barré. No autonomic involvement, no abnormal CSF involvement versus Guillain-Barré. 95. Rapid diagnosis. HIV+, low CD4+, watery diarrhea, Ucistin stool. DX and treatment. Cryptosporidium, nitazoxanide. 96. Rapid diagnosis. Landscaper and cat owner presents finger ulcer and nodules on the forearm with no signs of lymphadenopathy present. Spore trichosis ascending lymphangitis. Cat owner is irrelevant here, just a distractor. Papular lesions form along lines of lymphatic drainage. DDX. Bacillary angiomatosis. Cat scratch fever will have lymphadenopathy. 97. Rapid diagnosis. Patient with influenza, treated and improved. Patient then develops worsening fever and pulmonary symptoms. Secondary bacterial pneumonia. S. aureus and S. pneumo. Most common pneumonia is the most common complication of the flu and result of secondary bacterial infection or direct viral attack. Influenza pneumonia. Patient with primary influenza pneumonia will have bilateral, diffuse interstitial infiltrates and mild leukocytosis versus bacterial, which will have lobar infiltrates and high leukocytosis. 98. What is the mode of transmission for cutaneous larva migrans? Ancylostoma hookworm. Penetrates skin, most commonly barefoot from soil. 99. Rapid diagnosis. Patient with dry cough, fever, respiratory failure, and elevated LDH. What is the best test? Bronchoalveolar lavage. Most accurate chest X-ray. Should obviously always be done first. Induced sputum is the least invasive method, but if it does not yield a diagnosis, bronchoscope with bronchoalveolar lavage is required. 100. When should steroids be added to pneumocystis pneumonia? When PCP is severe. Partial O2 is 35. 101. What type of meningitis often afflicts young individuals with rapid onset of fever, myalgias, nuptial rigidity, petechial rash, and shock? Meningococcal treatment. Vancomycin plus 3rd gen cephalo. 102. Rapid diagnosis. Antibacterial treatment for dog, cat bite. Amoxicillin clavulanate augmentin. Avoid spontaneous closure unless facial wound. Pasteurella means cat or dog bite. 103. What is the empirical treatment of bacterial meningitis for all age groups? If you're 1 month to 50, vancomycin plus 3rd gen cephalosporin. Greater than 50, vancomycin plus ampicillin plus 3rd gen cephalosporin. For immunocompromised, vancomycin plus ampicillin plus cefepime 4th gen. Rules of thumb: really young lesser than 1 month, ampicillin, listeria, and cefotaxime prevent kernicterus. Kinda young to kinda old, vancomycin plus 3rd gen cephalosporin. Ceftriaxone. Old greater than 50, add ampicillin, listeria. Immunocompromised, look for option with cefepime to cover pseudomonas, and neonate. Cefotaxime is preferred over ceftriaxone because ceftriaxone can displace bilirubin from albumin, increasing the risk of kernicterus. 104. What enzyme is often elevated in patients with pneumocystis pneumonia? LDH. Other indications of PCP pneumonia include hypoxia, partial O2 lesser than 75 mmHg, and diffuse, bilateral infiltrates on chest X-ray. 105. Rapid diagnosis. Newborn with cataracts, deafness, PDA, VSD. Rubella. 106. How should you remove ticks? Tweezers. What is the time frame for prophylaxis? Lesser than 36 hours equals no prophylaxis. 107. What are the risk factors for rhino-orbital cerebral mucormycosis? Diabetes, ketoacidosis, neutropenia usually secondary to heme malignancy presentation, acute fever, nasal congestion, discharge leads to necrotic invasion of palate, orbit, brain treatment, surgical debridement plus liposomal amphotericin B. 108. The diagnosis of hepatitis C requires a two-step process that requires both a positive serologic antibody test and a confirmatory molecular test. Hep C virus RNA-PCR test. Treatment with direct-acting antiviral agents lenacapavir sofosbuvir should also be considered. 110. What is the diagnosis? What is the treatment? Patient presents with RUQ pain, nausea, and vomiting. The labs show eosinophilia and imaging shows a large cyst with septations, daughter cysts, and eggshell calcifications. What is the diagnosis? Echinococcus granulosus. What is the treatment? Albendazole. 111. Patient presents with RUQ pain, nausea, and vomiting. The labs show eosinophilia and imaging shows a large cyst with septations and eggshell calcifications. Why should you be cautious with treatment? Invasive procedures can produce life-threatening anaphylactic reaction. 112. Patients with Neisseria gonorrhoeae are at high risk of simultaneous confection with several other pathogens, including Chlamydia trachomatis, HIV, syphilis, and hepatitis B. 113. Management of neutropenic fever. Neutropenic patient with fever and neutrophil count of lesser than 500 includes broad-spectrum antibiotics, particularly anti-Pseudomonas beta-lactams such as cefepime, meropenem, or piperacillin tazobactam. These drugs cover both gram-negative and gram-positive bacteria. 116. The differentiating features that may separate the two include and acute HIV infection, acute retroviral syndrome presence like a mononucleosis-like syndrome with fever, night sweats, lymphadenopathy, and arthralgias. The differentiating features that may separate the two include diarrhea, mouth ulcerations, and rash. 117. Post-transplant measures that should be taken as universal prophylaxis for PCP with TMPS-MX and CMV with ganciclovir, valganciclovir. Should also monitor blood for 12 months for CMV and EBV viral loads. 118. Post-transplant measures that should be taken as universal prophylaxis for PCP with TMPS-MX and CMV with ganciclovir, valganciclovir. Should also monitor blood for 12 months for CMV and EBV viral loads. 119. What microorganism causes acute epididymitis in patients lesser than 35? Chlamydia or Neisseria, typically presents with unilateral testicular pain and epididymal swelling, usually secondary to bacteremia from bladder outlet obstruction in older patients. 120. Trichinelosis typically presents with GI complaints followed by characteristic triad of periorbital edema, myositis, and eosinophilia. 122. What is the likely diagnosis in an HIV patient with fever, cough, diarrhea, night sweats in the presence of splenomegaly and elevated alkaline phosphatase? CD4+ count is 22 and CMV titers are negative. What measure could have prevented this? HIV patients should receive azithromycin prophylaxis against MAC at CD4+ count lesser than 50. Splenomegaly and elevated ALK-P indicate Mycobacterium avium complex hepatosplenic involvement. 123. Gram-negative HACEK organisms can produce subacute endocarditis and are seen in patients with poor dental hygiene and or periodontal infection. Haemophilus, Aggregatibacter, Actinomycetum comitans, Cardiobacterium hominis, Eikenella, Corrodens, and Congela. 124. What is the most likely diagnosis in a patient from Arizona who recently went on vacation in the Northeast, who also happens to be an accomplished spelunker that develops fever, dry cough, and fatigue? Chest X-ray shows bilateral alveolar opacities and hilar lymphadenopathy. Bronchoscopic biopsy reveals granulomas with yeast forms. Histoplasmosis. Some patients require tissue diagnosis, which often reveals granulomas with narrow budding yeasts. 125. What is the treatment of choice in a patient with pneumocystis pneumonia and a sulfa allergy? Clindamycin plus primaquine or IV pentamidine TMPS-MX is the first line, but obviously contraindicated in this case. If G6PD deficiency, primaquine is also contraindicated, so use pentamidine for prophylaxis. You can use dapsone or oral ativaquone. 128. What is the likely treatment and method of delivery in an athlete that presents with a scaly erythematous pruritic plaque with a raised border and central clearing on their legs shown below? Topical antifungals clotrimazole, terbinafine. 129. What is the recommended prophylactic management in a healthcare worker who had a needle stick injury 3 days prior from a patient with positive Hep B? Patient had 3-dose Hep B regimen 2 years ago. Serum studies show negative results for HBsAg, HBsAb, and Hep C-Ab. Hep B immunoglobulin plus 3-dose regimen of Hep B vaccine. This patient did not respond properly to his previous vaccination. He should receive an initial dose of Hep B vaccine with HBIg as soon as possible. Next 2 doses can be administered according to the standard schedule. 130. What is the treatment for an HIV patient with multiple skin lesions showing vascular proliferation with a neutrophilic infiltrate? The lesion stain positive with Warthin starry stain. Erythromycin or doxycycline. Either Kaposi's sarcoma is similar, but Warthin starry stain suggests Bartonella. 131. What is the most likely diagnosis in a patient who recently traveled to Taiwan who presents with severe arthralgias, stabbing pain behind the eyes, and a maculopapular rash? Labs show leukopenia and thrombocytopenia. Dengue break-bone fever, retroorbital pain, fever, and severe myalgias are typically described by patients who have contracted dengue. 132. A patient recently traveled to Taiwan and now presents with severe arthralgias, stabbing pain behind the eyes, and a maculopapular rash. Labs show leukopenia and thrombocytopenia. What could have prevented this? Mosquito repellent. 133. What is the most likely diagnosis in a patient from Ohio who presents with a dry cough, shortness of breath, erythema nodosum, and hilar lymphadenopathy? Biopsy of the lymph nodes show non-casating granulomas. The patient is treated with corticosteroids for the suspected diagnosis but deteriorates over the next 48 hours. Histoplasmosis. Firstly, this presents more like sarcoidosis, hence the steroid treatment. In regions where these organisms are endemic, infection must be excluded before immunosuppressive therapy is initiated. Remember, the fungal infections histo and coccidioids can have erythema nodosum. Traditionally, histoplasma most commonly has casating granulomas but can have non-casating, such as this patient. 134. What is the treatment for a patient with the following lab values? Tenofovir preferred, entecavir, or pegylated IFN-alpha. Patient likely has active chronic hepatitis B infection. IgG to HBC indicates chronic HBV. HBeAg indicates current infectivity. Hepatitis B in 5 steps. 1. HBsAg, infection recent or chronic. 2. Anti-HBs, immunity vaccine or infection. 3. Anti-HBc, IgM recent or IgG chronic. 4. HBeAg, infectivity. 5. Anti-HBe, low infectivity. 135. Patients with chronic liver disease who are aged lesser than 65 require which pneumococcal vaccinations? PPSV23 alone followed by sequential PCV13 and PPSV23 at age 65. 136. Rapid diagnosis, regimen for HIV post-exposure prophylaxis. 2 NRTIs tenofovir, and tricitabine plus integrase inhibitor raltegravir. Just look for the above NRTIs in the answer. Don't worry about the second part of the regimen as that is variable. 137. Rapid diagnosis, hepatitis B serology shows plus HBsAb and plus IgG HBcAb resolved infection. 1. HBsAg, infection recent or chronic. 2. Anti-HBs, immunity vaccine or infection. 3. Anti-HBc, IgM recent or IgG chronic. 4. HBeAg, infectivity. 5. Anti-HBe, low infectivity. 141. What is the treatment for CNS lymphoma? High-dose methotrexate plus or minus whole brain radiotherapy. 142. What is the treatment for a neonate lesser than 1 month with bacterial meningitis? Ampicillin and cefotaxime. Rules of thumb: really young 50++ ampicillin, listeria immunocompromis. Look for option with cefepime to cover pseudomonas in neonate. Cefotaxime is preferred over ceftriaxone because ceftriaxone can displace bilirubin from albumin, increasing the risk of kernicterus. 143. What is the first choice 3 treatment of postherpetic neuralgia? Tricyclic antidepressants, gabapentin, pregabalin. TCAS are contraindicated in structural heart disease. Capsaicin is a reasonable second-line option. 144. What form of tetanus prophylaxis should a 50-year-old male receive if he has not had any vaccine since he was a young child? Tdap. Every adult should receive Tdap once and have a TD every 10 years. If someone in your question has never had a Tdap as an adult or is unsure, Tdap that shiz. 145. What is the treatment for a patient who had a positive PPD test 5 years ago but never received any treatment? All PPD tests since that time have been negative and chest X-ray is normal. Treat for latent tuberculosis 9 months of isoniazid. 1 active TB, first 2 months, isoniazid INH plus rifampin plus pyrazinamide plus ethambutol. Next 4 months, INH plus rifampin 2 latent primary TB. 9 months of INH, pyridoxine vitamin B6 can be added to prevent INH-induced peripheral neuropathy and sideroblastic anemia. 146. A parasternal heave is felt on the left parasternal area and suggests right ventricular hypertrophy. 147. What is the next step in management for a child with hip pain, fever, warmth, and swelling over the upper thigh? Labs show leukocytosis and elevated ESR. X-ray is normal and MRI shows periosteal elevation and osteolytic lesions in the metaphyses of the femur. Bone biopsy MRI, CT guided. Done before antibiotics, allows for culture and gram stain to guide therapy. MRI is the most sensitive diagnostic study in the workup, but biopsy is the best confirmatory test. 148. What is the empiric treatment for osteomyelitis in adults? IV vancomycin plus antipseudomonal cephalosporins or fluoroquinolones. Treat after bone biopsy is done. 149. Should empiric antibiotics be given before or after bone biopsy in suspected osteomyelitis? After. 150. What is the drug of choice? What patients should receive endocarditis prophylaxis? High-risk patients with heart defects, prosthetic heart valves, or history of endocarditis. What is the drug of choice? Amoxicillin 1 hour before procedure.